Please listen carefully.
Hello, and welcome to GasGasGas. This is the best podcast for the FRCA primary exam. Our goal is to fill your brain with all this highly useful information. You might be in the gym right now, commuting, or ironing your scrubs. Regardless, the revision is eventually going to end, but for now, expect facts, concepts, model answers, and the odd tangent. Make sure to check out GasGasGas.uk. The show notes there, there's loads more detail. Make sure to like and subscribe. Anyway, buckle up, get ready for your mind to be bent into a new shape, and let's get on with the show. Right, well, hello everyone, welcome to yet another episode of GasGasGas. I think this is the 43rd episode of the sort of pharmacology FRCA stuff. I think we did about 16 Vivacast episodes so far, and Tom is coming back. I think Tom needs like an alarm clock to remind him to set his alarm, but he's working on it. He dropped all the cash on the kit. Really, did enjoy getting grilled, so much so that he wants to return for a slightly more reciprocal grilling process that we're trying to devise. Tom is coming back for more Vivacast action, but I digress. I hope you had a nice week. We did dexmedetomidine last week, we're doing Clonidine this week. Hopefully you're having a reasonably pleasant Friday, or it could be a different day of the week depending on when you're listening. Let's try and get into the depths of Clonidine today. I'm sure you've seen it in the cupboard, seen it been used, wonder about it. It seems to be used in some places more than others, and there seem to be a number of preferences as to if they like to bolus it, if they're using it for ITU sedation, or using it to prolong regional anaesthesia. Not neuromuscular blockade. It doesn't do anything to neuromuscular blockade. Clonidine, neuromuscular blockade, no. So, class. Clonidine, like Dexmed, is an alpha-adrenoceptor agonist. It is a partial agonist, however, whereas Dexmed is a full agonist. Now remember the difference between partial and full agonist. When you have full saturation of all receptors in your system with a full agonist, you will see a maximal response from that system, whereas if you have partial agonists bound to all those receptors, even if every receptor is bound, you will only see a partial response as opposed to maximal response. Clonidine first synthesized in 1962, and actually first off they were using it as a nasal decongestant. It does seem that all these drugs found their ways into cough remedies and things, like heroin and cocaine, before it made its way to other such uses. It was also used as an antihypertensive agent. That's useful to bear in mind when you're thinking about using it, and helping people with migraines. But then its utility kind of became a bit more obvious, and it started creeping into pre-meds for anaesthesia and being used as a sedating volatile sparing agent. How is it presented to you? So it comes in either ampules, tablets or transdermal patches, and your ampule, it's a clear, colourless solution for injection, has 150 micrograms per mil. If you've got your pens and paper ready, guys, its molecular weight is 230.093 grams per mol, so it's slightly on the bigger side compared to everything else we've spoken about more recently, perhaps by about 10% or so. And my new favourite type of number is log octanol water coefficients. Remember, this is a way of objectively describing the lipid solubility or lipophilicity of a drug. Water, we know that's water. Octanol is an 8-carbon fatty alcohol. You mix them together in a beaker, you squirt your agent into it, then you measure the concentrations after a period of equilibration between those two chemical states. Try and figure out how much drug is in one versus the other, and I'm sure it's far more complicated than that. But the number we're interested in here, 2.174, so 2.1 orders of magnitude more Clonidine in our octanol versus our water. From last week we know Dexmed has this log water octanol coefficient 2.8, but the real winners are propofol and fentanyl, both greater than 4. Trying to remember to label pharmacodynamics of Clonidine. So this is what the drug does to the body as opposed to what the body does for the drug, which is kinetics. What is the mechanism of action of Clonidine? We need to know that first, really, don't we? So it acts by stimulating mostly presynaptic alpha-2 adrenoceptors. Reminding you guys, it's a partial agonist. What this does is it inhibits noradrenaline release across that synaptic cleft, impairing signaling in whichever structures this molecule is binding to. What effects does that tend to achieve that we're interested in? So it's going to deliver a bit of analgesia, although the jury is out. I'm just going to say it could either be inhibition of endogenous substance P secretion or stimulation of endogenous opioid release. Depending on what you read, depends on what they say. It has a depressant activity on your sympathetic nervous system. Prolonged use desensitizes your vasculature to vasoactive substances. Curious. And it may also increase vagal tone. What is the clinical utility, i.e., what things can we use clonidine for? So, helps with blood pressure. Well, are we really going to reach for that during an anaesthetic? Well, there's probably better drugs during an anaesthetic to manage just blood pressure. But it also, as we know, has analgesic effects, it has sedative effects, and in low doses, anxiolytic effects. In high doses, it actually makes people anxious. You could brand it as causing sympatholysis, some people like that word, and by virtue of that, it can be used to mitigate the initial elements of the surgical stress response, i.e. you've got a fast heart rate, you've got a high blood pressure, your body's working harder whilst that clonidine is still in system after your intraoperative doses. It also seems to reduce post-anaesthetic shivering, although I think we see less and less and less of that. It is somehow an anti-emetic, but we're not using it for that, are we? It does obtund tourniquet-induced hypertension, that might be somewhat useful, and it naturally does decrease post-op agitation in patients and chiefly kiddies who've been sevofluorined, because they do love having sevoflurane emergence delirium, does the little ones. From a non-anaesthetic utility perspective, because we have to think about other people, don't we? It could be used as a migraine treatment, although isn't. It can help with menopausal flushing, although is not. It does mitigate opioid and alcohol withdrawal. That's probably where it does come into use. In ITU, actually, probably indirectly we're treating people who are rattling, and we just think they need more sedation because they drink. It's probably because it's actually helping with the withdrawal. And it's a chronic pain adjunct and a cancer pain adjunct as well. How do we dose it to achieve these clinical effects? Well, orally, 50 to 600 micrograms. So that's max 1,800 micrograms in a 24-hour period. Orally. IV, intravenous dosing, ranges quite widely from 1 to 3 mics per kilo. That'll do your pain, that'll do your blood pressure. IV onset time, about 10 minutes, and 3 to 7 hours of slow offset of that drug. Those are the licensed routes. Now, non-licensed, we end up in our situation where we've got a drug, there's a lot of literature that suggests we use it, but it's off license just because no one's gone and pursued that license because it's an unnecessary expense to the drug manufacturers, probably. So epidural doses up to 150 micrograms. Intrathecal doses, 30 micrograms. Both of these prolonged block, give better pain relief, perhaps peri/post those blocks. Not terribly commonly done. More often than not, it's given at a sort of like mic per kilo dose regionally, but you do end up seeing just the systemic side effects of that perineural dose. So I think if you're trying to augment your regional blockade, you're probably better off just giving it IV slowly, because otherwise you'll end up with some side effects, much like Dexmed. And in terms of the other big use that I'm sure a lot of us see is its use as an adjunct in intensive care sedation. Now, eventually it might be that dexmedetomidine takes this over, but for now there's a lot more institutional familiarity with clonidine because it's simply been available for longer, because it's been off patent and therefore cheaper for longer. I don't know why all the surgeons get fancy brand new dynamic hip screws and then we're lumbered scrabbling around in the bottom of the sharps bin for some Dexmed 15 years later or whatever it was. Alas, ITU sedation, generally speaking, 0 to 2 micrograms per kilo per hour. Although I think some of the world is still coming around to this mic per kilo per hour, and they like to just say there's 5 mils an hour of clonidine and 10 mils an hour of double strength noradrenaline, but it fails to take into account the mass of the patient. So mics per kilo per hour, it is better. How is it drawn up? So generally speaking, if you're doing an infusion on ITU, expect it to be in normal saline or 5% dex. Classically, 750 micrograms in 50 ml is considered single strength, and 1,500 micrograms in 50 ml is double strength. Now, if we just want to think about our standard 75 kilo patient, if they are on single strength and you were aiming for a mic per kilo per hour, they'd be on a 5 ml an hour infusion. If you're going to stick them on max rate on single strength, you'd be on 10 mils an hour. Now, what happens if you overdose patients on drugs? Well, classically you get more clinical effect, but more clinical side effect as well. 1 to 2 mics per kilo per hour seems like a reasonable place to start. Now, one of the beauties of Clonidine, A, it comes in tablet form as well, and B, its oral bioavailability is almost 100%. So you could step down your patient from your ITU sedation infusion to an oral version, because you don't want to abruptly stop it. Talking more about that in a minute. There's a bit of a theoretical limit, so to speak, on what you should and shouldn't be giving orally. So it was more sensible to look at local guidelines for Clonidine ITU sedation as opposed to taking quotes from me on how to step them down to an oral version. The most important thing is abrupt cessation causes quite stark hypertension, sweating, agitated patient, which you don't really want if you just extubated them yesterday and then they go delirious bonkers and you're trying to them back down. Not a good look. So don't just stop if you've been on an infusion. Pharmacodynamics, side effects. We've talked about clinical utility and what we sort of hope to get out of it, but we always have to tolerate side effects of drugs as well. And there's quite a number of cardiovascular side effects for Clonidine. So when you give it intravenously, remember that achieves quite a high initial peak plasma concentration, especially if you give it quite quickly, you will see an early increase in blood pressure. This is because you are stimulating vasculature alpha-1 adrenoceptors. You're giving them a tickle and that smooth muscle's going, let's be tight. After this initial phase, you're going to see some degree of hypotension, quite probably. From a chronotropy perspective, it's a negative chronotrope. You'll see a bit of bradycardia. Now, it's not a directly negative chronotrope. It doesn't act on the heart and say, hey, whoa, slow down, in as much as it's more of a sympatholysis perspective. And also, it does some crazy stuff where it sensitizes your carotid baroreceptors. So for a given blood pressure, you will see a slightly starker heart rate drop, interestingly. Cardiac contractility, inotropy, unaffected, but with that sympatholytic process that's coming about, it is a negative dromotrope, i.e. it's going to slow down conducting system conduction. You get a longer PR and slowed AV conduction. Other stuff, the jury's a bit out on what it does to the coronary vasculature. It certainly causes local vasoconstrictive effects, but also you get the systemic sympatholytic effects. Those local vasoconstrictive effects are probably going to wane, whereas the central sympatholytic effect is probably going to remain. We've noted the rebound hypertension that you get with Clonidine, seemingly more prevalent than with dexmedetomidine, more likely if you're on big old doses. Central nervous system effect, it decreases your cerebral blood flow. For the doses that as anaesthetists we're using it in, it probably drops MAC by up to 50% if you're giving a big dose. I noted earlier, low dose Clonidine anxiolysis chills you out, but if you're in the higher dose category, so above what we've spoken about, you actually get a degree of anxiety. This is likely due to the fact that it's less Alpha-2 specific than Clonidine. Remember, Clonidine prefers an Alpha-2 receptor over an Alpha-1 receptor, 220 to 1. Dexmed, 1620 to 1. Now, central Alpha-1 agonism has somewhat contrary effects to central Alpha-2 agonism, so it can actually start antagonizing the effects it's trying to create through one system via the other. Gives you a dry mouth and lowers your intraocular pressure. Respiratory-wise, it does very little to your minute ventilation in the clinical doses. If you're giving supraclinical doses, you may see respiratory depression, but we ain't going there. It has a mild diuretic effect when we're thinking about the kidneys, and from an endocrine perspective, it can cause the rate of insulin release from your pancreas to go down, and you might see a creep up in your blood glucose. Not really relevant for theatre cases, but perhaps something to consider in ITU, although everyone's just on an insulin infusion, so you're not really going to see it, are you? So that's the dynamics of Clonidine. Chiefly, you're going to see high blood pressure, then low blood pressure. You're going to expect a bradycardia. Your patient's going to be dozy and sedated, and they might be dozy and sedated in recovery as well. It may smooth out your emergence from anaesthesia. Don't abruptly stop it on ITU. You'll certainly have a bad day if you do that, by means of having to pin down someone going mad. Anyway, whilst you imagine trying to wrangle a agitated ITU patient back into bed, we should move on to pharmacokinetics. So remember, pharmacokinetics, in the exam, you're going to say, well, break this down to an absorption, distribution, metabolism, and elimination. Absorption. Clonidine, 100% oral bioavailability, or near enough, and also can be absorbed transdermally. Distribution-wise, we note that it is very lipid-soluble, although slightly less so than dexmedetomidine. Therefore, it gets into the central nervous system easily. Its volume of distribution could be quoted as 2.1 litres per kilo, or as a range 1.7 to 2.5 litres per kilo. It is only 20% protein bound. Metabolism wise, clonidine is 50% metabolized by the liver. It is metabolized into one active metabolite, 4-hydroxyclonidine. However, the lipid solubility of this drug is, as you would imagine, worse, because the liver generally shifts most drugs from being lipid soluble to more water soluble, and a number of other inactive metabolites. The chief enzyme that we're interested in here, about 66% of the activity is CYP2D6, and then there's a bit of 3A4 as well. We should always just briefly touch on enzyme inhibitors when we think about this. So CYP2D6 inhibited by fluoxetine and paroxetine. Eventually we'll do a full episode on enzyme inhibitors and inducers. Elimination of clonidine. About 40 to 60%, or perhaps 50%, is excreted unchanged in the urine. Its elimination half-life ranges, depending on where you read it, 6 to 23 hours or 9 to 18 hours in Peck and Hill. As you'd expect with a drug that is somewhat renally cleared, 50% of it being via the kidneys, 50% approximately being by the liver. If you have really bad renal impairment, you will accumulate clonidine, i.e. GFRs less than 10. Clonidine does not dialyze out of plasma. So if you've given someone a clonidine infusion who has renal failure, then you are reliant on the liver component to clear that agent. As we mentioned earlier, other important things to note beyond that is sudden withdrawal of clonidine leads to your agitated, sweaty, hypertensive patient. If they've been on it for several days, reduce the dose over 36 hours before maybe getting to something that's a bit more compatible with oral dosing. The MAC reducing powers of clonidine are based on obviously observed patient depth of anesthesia, but also some of the early studies were using halothane. Now, unlike dexmedetomidine, whereby the higher and higher and higher the dose you gave, the less and less MAC you need, because it so heavily favours Alpha-2 receptors over Alpha-1 receptors, so you don't get that contradictory effect at higher doses. Clonidine doesn't tend to have the ability to go above a 50% MAC reduction, because again, you end up with that Alpha-1 receptor tickling action that counters things. What does that mean? It means that one day dexmedetomidine is certainly going to replace clonidine, isn't it? It seems like a better all-round drug. It was just more expensive, and that's why we didn't get our hands on it. Until now, it is creeping into places. So we've been a bit sparse on segues in this episode, because mainly we've just been getting on with a drug that we've already talked quite a lot about its class in the previous episode. But I'd like to just draw everyone's attention to the structure we had for approaching the cardiovascular effects of clonidine. We broke it down into systemic vascular resistance and then its effects on chronotropy, inotropy, dromotropy, and these tropies of the heart, originally devised by someone called Engelmann in 1897. There are 5 tropies of the heart. The action is lucitropy, and this is the capacity of the heart to relax and how agents and physiological states can alter the capacity of the heart to relax. So chronotropy, inotropy, lucitropy, dromotropy, and last but excitingly not the least is bathmotropy. I don't quite know why we called it bathmotropy, but that is the level of excitability of the heart. So how lively it is, how ticklish it is, so to speak. And you can imagine a heart that's predisposed to dipping out of arrhythmias and is all having a party in there and getting really jazzed up would be, positively bathmotroped. What are positive bathmotropic situations? Things that increase myocardial excitability, such as adrenaline, digoxin, dobutamine, dopamine. Things that are negatively bathmotropic, beta blockers, amiodarone, you'd expect that, antiarrhythmics. And states such as really severe hypocalcemia, where patients can tip into VF. In an episode on cardiac physiology, we've spoken about clonidine. We have covered its partial agonism effects, explored its side effect profile, and its early high blood pressure and later low blood pressure bradycardic type state. We note that it has many useful features and clinical utilities in anaesthesia in terms of sedation, analgesia, mild anxiolysis, might make people shiver a bit less after their operation, probably smooths out emergence in adults and kids, and you could use it as an antihypertensive, and it has uses on ITU for sedation. We've compared it at a number of steps with dexmedetomidine, and hopefully if I say Alpha-2 agonist enough, it'll end up in your brain and staying in my brain. Anyway, thank you very much for listening. I hope you have a nice week. I think next week we're going to push through and start doing the volatile anaesthetic agents. Or we might put out another quiz-like episode, but do it for all the opioids, comparing and contrasting which has a high pKa than the other, which has a higher protein binding than the other, and all that exciting jazz, so you can do questions as you drive home. So I'll see which way the wind blows, and we'll do something like that. Have a nice weekend. Cheerio and goodbye. Thanks for listening, guys. I hope you found it useful, but if you found it awful, do let me know. Please like and subscribe, register with whichever podcast platform you find yourself using, and leave a comment if you think I need to square something away. I just want to make sure that you guys know that every day you are getting better at this. There is a bucket of content to try and consume, and it is like drinking from a fire hose. Take it day by day, don't overcook yourself, don't freak out, and keep studying.